Hello, and welcome to the webinar. My name is Julie Hashida, and I will be sharing logistics for today's webinar entitled Medicaid's Home and Community-Based Services Program, an orientation for homeless healthcare providers, a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration Office of Special Population Health. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. A selected number of questions will be answered at the end of the presentation during the Q&A session. Thank you. I now turn the mic over to your event host, Sabrina Edgington. Sabrina?
Thank you, and welcome to today's webinar, Medicaid's Home and Community-Based Services Program, an orientation for homeless healthcare providers. My name is Sabrina Edgington. I'm your event host. I'm also the Program and Policy Specialist at the National Healthcare for the Homeless Council. I'm really excited about our three primary presenters today. We have Marty Knisely, who is the Director of the Technical Assistance Collaborative's Community Support Initiative, which is focused on assisting states to establish flexible community-based services through state-level policy development and financing. Marty will describe Louisiana's Home and Community-Based Services Program at a more macro level, so how the program came to be and how it's structured. We also have the beautiful Christine Rohr, who is the Housing and Homeless Coordinator at Louisiana's Office of Mental Health. Christine will provide more on-the-ground level information about how the Home and Community-Based Services Program is working in Louisiana, and she'll provide some case examples. We also have Carla Pope, who's the Senior Project Coordinator at the Iowa Finance Housing, or the Iowa Finance Authority, that is. And she'll talk to us about a really innovative program in Iowa that provides rental subsidies to individuals who are eligible for home and community-based services but lack housing. But before Marty, Christine, and Carla go into their presentations, I'd like to provide an overview of home and community-based services, since this is an orientation and there are several home and community-based service programs. And it's important to be able to distinguish between the different programs so that you can have an informed conversation with individuals in your state. So Congress created the Home and Community-Based Service Program to allow individuals to live more independently in a home and community-based setting as opposed to an institution. So not only is this an effort to improve quality of life, it's also a way of reducing federal costs, much of which is being directed at institutional care. There are several different home and community-based service programs available, and this is the case because it provides flexibility to states to improve access to targeted populations. Today we'll talk about three. We're really going to be focusing in on the middle one listed, the 1915I program. These programs are referred to by the section of the Social Security Act that created the program, where the authority for the program is housed. So we'll talk about the 1915C, Home and Community-Based Services Waiver, the 1915I, State Plan Home and Community-Based Services Program, and the 1915K Community First Choice Program. One thing that's important to note is that states electing to offer home and community-based services through one of these programs are eligible for federal financial participation, so they can receive a federal match for providing these services. So where states are paying for these services with state-only funds, this would allow them to bring in some federal money and use some of their state funds to expand services to a larger group of people. So the first program I want to talk about is the 1915C, Home and Community-Based Services Waiver. And I wanted to talk about this because this is the most commonly adopted home and community-based program in the country. Almost all states have one or more of these home and community-based service waiver programs in place. This program is one of the more restrictive programs. So to be eligible for this program, individuals must demonstrate the need for a level of care that would meet the state's eligibility requirements for services in an institutional setting. So states have the flexibility to determine what those requirements are. It does come with a package of services that are eligible for federal match, and that is case management, homemaker home health aid services, adult day health, habilitation, caregiver respite care, as well as services for individuals who have chronic mental illness. And then the state can also propose some other services to help with transitioning an individual from an institution to a community. So as with all Medicaid programs, there are a number of requirements as well as options. For this program, states have to submit an application for a waiver. And I mention that because submitting an application for a waiver is a much more arduous process than submitting a state plan amendment, which would be the case for the next two programs that I'll be talking about. The program must be budget neutral, meaning that the waiver services won't cost more than providing these services in an institution. Services need to follow an individualized and person-centered plan of care, which is the direction we're going with health care right now anyways. And then states can waive state wideness. So this is a waiver because you can waive certain provisions of the federal Medicaid program. So one of the things that you can waive is the state wideness provision, meaning that you can target waivers to areas of the state where the need is greatest or where certain types of providers are available. Additionally, states with this 1915C program can waive comparability of services to make the home and community-based services available only to certain groups of people who are at risk of institutionalization. So in a lot of states, you'll see waivers that are targeted directly to people who are elderly and might be at risk of nursing home placement, or individuals with traumatic brain injury or diagnosed with HIV/AIDS. So in many cases, states have several programs targeted to these various different groups. The 1915K Community First Choice Program is important to know because it's getting a lot of attention right now. The Centers for Medicare and Medicaid Services just released its final rule on this program, so there's a lot of talk about how this is going to be implemented across the states. Again, the eligibility is a little bit restrictive. Individuals have to demonstrate the need for a level of care that would meet the state's eligibility requirements for services in an institutional setting. They have to have incomes up to 150% of the federal poverty line or higher if the state has a higher income threshold for Medicaid eligibility. The services in this program are a little bit different. They are really focusing in on the attendant services and supports to help with ADLs and instrumental ADLs, that's activities of daily living and health-related tasks, some of which can be provided through the 1915C, but also provided through this 1915K program. But one provision that makes this really interesting is that beneficiaries may self-direct services, meaning they can hire and fire providers, and they can hire their own family members to be their providers if they so choose. States can cover transition costs, and those transition costs can include a month's rent or utility deposits, kitchen supplies, bedding, or other necessities for an individual to move from a nursing facility to the community. States can also cover some other services to help increase independence. What's excluded are financing home modifications, room and board, medical supplies, and assistive technology. So those are excluded from being provided under this program. Again, certain state requirements and options. There are many. This just covers some of them. But one thing that's worth noting is that states selecting this option can actually receive a 6% increase in their federal matching payments. States must also make services available statewide. This is different from the last program I just mentioned where they could waive state wideness. So with the 1915K option, the services must be made available to everyone who's eligible in the state. And there can't be any caps or targeting by age, severity of disability, or any other criteria, so that again is different. And then another really interesting feature of this program is that states can establish, or they must establish, that is, a development and implementation council to collaborate on program design and implementation, and the council must have a majority of membership made up of the people who the program aims to serve or their representatives, which is a really nice feature. So really, I want to focus on the 1915I State Plan Home and Community-Based Services. This program we want to focus on because this is one program that has a lot of potential for serving people experiencing homelessness who have other illness and disease that we've been working with. Eligibility is less restrictive for this program. The state may provide services and supports before an individual needs institutional care and to individuals with mental health and substance use disorders. So really the intention here is that if you don't provide these home and community-based services now, then the person might deteriorate to a point where they might need institutionalization in the future. Again, there's some income requirements with this program. The services with this program are the same as the 1915C, but the state can request other services that might be used for targeted populations, and I'll talk about that in the next slide. So some of the state options that are really great about this program is that states can disregard comparability, which we talked about earlier, in order to target individuals with specific diagnoses and conditions, or even broader than that if they choose to do that. Just a note, targeting criteria is different than needs-based criteria. States can also elect to cover individuals who are otherwise not eligible for Medicaid, but meet the state's needs-based criteria for the 1915I program and also meet that income criteria. So in a lot of your states, people who are experiencing homelessness, especially our single males, may not be eligible for Medicaid, but if they meet this needs-based criteria, then the state can elect to not only provide them with the home and community-based services program, but also the full Medicaid package, which is a really great feature of this program. This program allows states to provide the 1915I services to individuals with incomes up to 300% of the SSI federal benefit rate, but that's only if they meet the needs-based criteria under the more restrictive 1915C program, as well as the D&E waiver programs, which we didn't go over, or existing 1115 demonstration waivers. States can also phase in their state plan home and community-based services program to those with the highest needs, but they must enroll all eligible individuals within the first 5 years of the program, or they cannot renew their program. So that's important to note, especially if you're working with your state to be identifying individuals who are eligible for this program. And states can also elect to include 1959 benefits as part of a managed care contract. Now, some state requirements of this program is that the 1915I home and community-based services need-based criteria must be less stringent than the criteria for the 1915C program. States cannot limit the number of people receiving 1915I home and community-based services or create waiting lists. Rather, what they can do is project the numbers to be served and then constrict needs-based criteria if numbers exceed projections. So it's important if you're working in an environment where you're targeting people who are experiencing homelessness, who have chronic disease, it's important to be able to try to accurately project those numbers so that you don't have to constrict those needs-based criteria later. States also have a lot of quality assurance strategies that they'll need to have in place, but one in particular that we like is that it includes the availability of an independent advocate to assist the individual with access to and oversight of their home and community-based services program. Another thing that I'd like to mention just very briefly in terms of practice is that the Centers for Medicare and Medicaid Services does distinguish between an evaluation and an assessment. So whereas the evaluation is the needs-based eligibility requirements, the assessment is a different approach, which is basically determining, after you've been determined to have certain needs and you're eligible for the program, the assessment is to determine what specific services the individual will qualify for. CMS does distinguish between agents and providers. There is a conflict of interest provision in there, so the person doing the independent evaluation or assessment cannot have a conflict of interest with the providers. While the provider can participate in the development of a care plan, for example, the independent agent retains the final responsibility over the evaluation, assessment, and care plan. And so I thought that would be important for our providers to know as they're trying to connect your patients to home and community-based services. And that is just the brief overview of these three programs. And at this point, I'd like to hand it over to Marty, who will talk a little bit more about Louisiana's program and how they've been able to take advantage of this federal program.
Thank you, Sabrina, and really pleased to have the opportunity today to talk about Louisiana's Permanent Supportive Housing Program. I'm going to start with a brief overview and then get into the 1915I services. These services, 1915I and 1915C services, will be made available to qualified recipients of the Louisiana's Permanent Supportive Housing Program. This program got started back in the wake of Katrina as part of the state's overall road home recovery plan. And to date, as a result of that action and those activities, over 2,400 people have moved into permanent supportive housing. They have been primarily served with the road home funds to date. But we knew back in 2000 and 2006 and 2007 that those were temporary services funds. So the Department of Health and Hospitals, which we'll talk more about in a minute, began very early on looking to Medicaid as a fund source for services that would be reimbursable, because the potential tenants for this program would be both Medicaid eligible and then that would be enrolled in specific programs. We didn't know at the time that those would be I services or C services, but it's always been the intention of the Department of Health and Hospitals to establish what we're calling a sustainability plan, and therefore they had the benefit of standing up a permanent supportive housing program that would take into account a number of the Medicaid requirements that we now know about. So the original program, that stands today, was created by a group of, at one point, very loosely organized group of people. They've become very formally organized now, that included advocates, philanthropy, and state human services and housing officials, as well as homeless advocates. I might note here that the Department of Health and Hospitals, which is their big umbrella agency, was already beginning to look, and had a Real Choice Systems Change Grant from HHS to begin to look at housing opportunities for people with disabilities just prior to Katrina, and that was really very helpful to get the state involved. The initial program design, and this is important as you get into the specifics of the 1915I services and why this works, is that the initial program design created first a partnership between the housing agencies and the human service agencies, so that you would start out with the right folks being in the room, which again is needed all the way down the line. That they would have a housing production strategy, and we won't go into that today because today's conversation is mostly about the services. And then an infrastructure at the state level and at the local level to do outreach, referrals, community-based service delivery, and make sure that there was a relationship with landlords and owners. Because the housing in Louisiana, as part of the road home plan, just by definition, they were moving more to a scattered site model to take advantage of the federal programs that were getting stood up on the housing side within Louisiana. So they put together also then a services sustainability plan and a formal targeting plan policy, which again has become very important, and my colleague Chris Rohr in a few minutes will talk about that. So, can't get it to move here. Okay, so the state level partnership, I won't spend too much time here, is really between the Office of Community Development, which is also now the Louisiana Public Housing Authority, and the Department of Health and Hospitals, which does set the targeting policy, does the outreach, referral, et cetera, that we just talked about. The governance, again, this is important. they've moved from this loose group of people into an executive management council, which makes the policy decisions, and it includes the state's Medicaid director on that council, as well as the assistant secretaries and the DHH-PSH program director, again, my colleague Chris Rohr. So that governance was in place to make the kinds of decisions to go forward to get access to home and community-based services and to the I services. Then they had a local PSH management that originally started out with 6 regional agencies managing the resources, making sure that people got into housing. Again, you can see the services were based on a housing first philosophy. There was training built in for these agencies, and they really focused a lot on outreach to make sure that they were getting referrals of people who were their highest priority. They also tracked housing referrals. They collected all kinds of information necessary to run the program, but also to match it against Medicaid data before they even moved to Medicaid services. So the people that were moving in, remember, they haven't gone for Medicaid services yet. The people who were moving into these units, they can tell you how many people were eligible for Medicaid or were made eligible for Medicaid, and what services they were using. That's been extremely helpful in being able to stand up this program. They also put in processes for eligibility determination, and the staff here, even with a very severely disabled population on the streets and in and out of institutions, they've had a very good success in making people eligible. Then they moved to a new management and infrastructure in 2011 and are still going through the process of that change. What you really need to know about the change are 2 things. One, the temporary funds that they had available post-Katrina will be going away, and they will be standing up a program that is almost totally reliant on Medicaid-funded services, Ryan White services, and then a limited amount of state funds that can be made available. And in this environment today, getting state funds is a real challenge. So what we really wanted to do was to develop a design that would take advantage of these Medicaid programs. So the PSH service interventions, already created interventions, were added to these programs, were added to the 1915I and to 1915 B and C services. We're only going to talk about the I and a little bit about the C today. They were added. In other words, how people get services and help them stay in housing is actually part of the Medicaid service definition today. So then the next thing they did was they knew that the funds for managing this program would also be going away, and there would no longer be a structure to manage them that was part of the hurricane recovery. So they put into both their waiver, the 1915I applications to CMS, as well as into the RFP for a newly contracted managed care organization to take over the responsibilities of local management. And this was, as I said here, changed. This was a change. They're using the behavioral health managed care organization, but they have interagency agreements between that will be put into place between the management of services for people with behavioral health needs, as well as for people with health care, long-term care, and DD. In other words, one management entity across the entire spectrum of the disability population. So that management organization is responsible for outreach, screening, making referrals for housing, tenant services management, contingency fund management. They have some funds for people to move in, and then tracking and reporting. But they are also responsible for managing a behavioral health services provider network and care management for people who actually qualify for the I. So if we had a giant schematic that you could look at, you could see these relationships and how interdependent they are to be able to continue this cross-disability arrangements. For the I services and the B, they have the actual managed care company has a combined risk and management only contract, and they can make alternative payment arrangements that's very helpful for people in permanent supportive housing. They will have to certify that the providers meet qualifications for not just the services, but there will be a special certification to be a permanent supportive housing provider in addition across, and they were going to do that for all of the disability groups. Then they will have new training and competency requirements for all new providers. They're basically relying on a core of about 10 providers today, and as this program expands and goes statewide, they will be adding additional folks in. So there are two services under the I that have particular applicability to our discussion today. One is called CPST, one is ACT, which many of you may be familiar with. These services are in vivo. The statewide management organization, the managed care organization, must make sure that there are sufficient number of providers in each region of the state going forward. And again, they will do what we call care management, which is really making sure service recipients and providers can navigate this whole system and assure support is available during what we call critical transition periods. In other words, assertive outreach, going out to where the person is, being available to them, and making sure that somebody is tracking that very actively. And they will also make sure that people will get the amount and type of services they need to stay stably housed. There is a long laundry list here, bulleted right from the CPST service description. This is now a 1915I service in Louisiana, and Sabrina was talking to you about the needs-based reviews and the outside assessment, etc. I'm not going to go into those details, but they are all included in the specific Louisiana program design. So you can see that, again, there is an independent assessment. This is based largely on functional needs, and this makes, I think, our job as helping people get and keep housing even better. I'm going to go down to the next to last bullet under CPST, where it says restoration, rehabilitation, and support to develop skills to locate, rent, and keep a home, landlord-tenant negotiations, selecting a roommate, and renters' rights and responsibilities. That statement basically means that staff working with potential tenants guide them through the process of getting into housing and helping them remain stable and helping them negotiate what they need to negotiate with either a roommate, a landlord, or and understanding their rights and responsibilities. You will see the last bullet refers to assisting the individual to develop daily living skills, including managing their own home, which is extremely important. Above that, you will see, oops, wait a minute, I'm going the wrong way. Oops. Wait a minute. Right above that, you will see that there are also other parts of this definition that relate to what's helpful to help people get and keep housing. But those last two bullets in particular, I just wanted to highlight. On ACT, this is not an atypical ACT, or this is a typical ACT definition based on the various fidelity measures that are used today for assertive community treatment. Again, I will not go through it except to say that that definition also includes the same requirements. Okay, so so those are the services. And we thought that the other helpful discussion today about Louisiana's program is about the targeting of the populations so that we could make sure that people most in need of housing were and services were actually going to be able to get into the units using both a big mainstream housing program and a big mainstream services program. So I'm going to ask my colleague, Chris Rohr, who's is the director of the Permanent Supportive Housing Program here in the Department of Health and Hospitals in Louisiana, to take it from here. Chris?
Thank you, Marty, and I am very excited to talk about our target populations because it was such an interesting process from the beginning. I think what I'll start out with is to explain to people a little bit about the Department of Health and Hospitals. As Marty said earlier, we are an umbrella organization, and we do house the state Medicaid office, which has tremendous advantages. We also house and are responsible for services to people with behavioral health disorders, including mental health and addictive disorders, citizens with developmental disabilities. We house also what is an Office of Aging and Adult Services, which deals with adult onset disabilities, as well as the Office of Public Health, which manages most of the HIV/AIDS programs in the states. So it's a very convenient umbrella to be working in an endeavor like this, and because we're responsible for serving across disability population, and as such we were determined from the beginning to make the PSH program a cross-disability program rather than what we have traditionally seen programs that were developed with different, silos of types of disabilities, restricting others. We developed this with a very interesting and I think significant array of advocates at the table, and we tried very diligently to make sure that everybody got to the table and everybody got to put their say-so in terms of how we were going to target these populations and the type of outreach that we were going to do. And it was an extremely laborious process. It actually took us about 6 months, but I can tell you, as painful as it seemed at the time, it was well worth it in the end with what we've been able to pull together and accomplish. So I recommend highly that you undertake that. The program is eligible for people who are extremely low-income households. We specifically wanted to make sure that what we developed was going to be reachable to our folks who are on disability incomes. They do need to have a disability, and they have to be what we call in need of permanent supportive housing, which just means that they need services. They're not required to accept them, but they do need to have a service need in order to get and maintain their housing. And these were our basic threshold criteria. And upon that, you can see the indented bullets near the bottom that we had some preference groups that we were able to set up. And of course, since it is a disaster recovery program, we gave high preference to those people with disabilities who had actually been physically displaced by the hurricanes. We also wanted to target people who were homeless or at risk of homelessness. Obviously, we had a lot of that after the disasters. We also had a lot of people living unnecessarily in institutions or at risk of institutionalization, and that was an effect that we have issues with like every other state, but because of the disasters, a lot of people were put into institutions because there was no place else for them to be, and it was, I believe, intended to be a temporary situation, which then became more permanent. So we're still providing outreach and discovery on folks who are in that type of situation. Additionally, we have a goal of at least 1/3 of all the PSH households to be homeless. And we're sincere about making that a minimum. And we have, I think you will see in future slides, that we are doing a really good job at making sure that we tap into the homeless population. Currently, as Marty said to you just a few seconds ago, that we are shifting our services to a more sustainable plan away from the disaster recovery money and into the mainstream services. So we've had to adjust our eligibility requirements to include the requirement that applicants need to be eligible for federal or state-funded services programs. They don't have to be receiving them, but they do need to be eligible. And as she also said, we have been working diligently to identify every type of service program that is in existence that we can make available to people. Other than that, all the requirements are the same. The people who have gotten into the program fall into some fairly broad categories of disabilities. Those that are health-related, those that would tap into a long-term care service need, households with qualifying members with disability, developmental disabilities, and a large number of folks with behavioral health issues. And here you'll see some of the demographics of the people who are involved in the program. Our average household size is 1.7, which says that we obviously have a lot of single households, but we also have families, and some of them can be as large as 10 people. Our age is, average age is 46, so we have not a young population that we're serving, and I think that speaks a lot to the whole concept of aging in place as being one of the goals that this program is going to have to be looking at as we plan for our future. Ethnicity and race, we have a large number of African Americans, but I think we've got a fairly good spread overall. Singles versus families, you'll see, which is not uncommon, that in the shelter plus care homeless situation, we have a predominant majority of singles, but in our project-based voucher section, we have a pretty even split of singles and families. In our population targeting, we have 58%, which you'll see is very much more than that 1/3 we were shooting for, who are homeless or at risk of homelessness. But we have only 10% that are institutionalized or at risk of institutionalization. And that alludes to the difficulty that it takes to get people out of institutions, but also, like I said earlier, that we're still uncovering folks who have been placed in institutions shortly after the storms and still need help in getting out. In our program access, we have about a 5% turnover, which I think is not high for a program that serves people with severe disabilities. And because we have services that specifically target people to assist them in working with landlord relationships, we've really had very few evictions. And those definitely are our goals. Housing retention is one of our biggest goals. Our disability status, I think we have a pretty good spread on that as well. You'll see that our diagnoses range from DD, mental health, substance abuse, health-related, and then our basket category, none or other. And the substance abuse, you'll see the asterisks by that, and we really think that this is a very underreported situation in our population. And more often than not, we gather that information not from the individual themselves, but from the service workers who are working with them. Much of this data was actually taken from what people reported on their application and what went into our housing database. So we think that people were reporting other disabilities instead of the substance abuse, which is why that one looks low. You'll see we have quite a few people with mental health disorders. That's almost half. And so when you add that with the substance abuse disorders, we have the majority of our population with some type of behavioral health issue. And our health-related issues, is a real mixed bag, but it includes folks who either are receiving or eligible for some type of long-term care service, and those who do not, but bear looking into their situation further. Okay, I'm going to rush into some case examples because I know that's something that you really are interested in. I tried to get a good mix on that of both small town, urban, and more rural area. Our first one is a small town, and that is tenant QS, who entered the PSH program with a history of cutting on herself out of anger and a long history of drug abuse. Because of that, she had her children removed. She was rejected by her family and became homeless, living from place to place. She heard about PSH from an aunt, applied and qualified for a shelter plus care subsidy, and was placed in a PSH unit. She continued her drug abuse and her cutting on herself, but was still able to stay in her unit for about a year. And the team helped her with the landlord issues that she obviously had. With this landlord, those couldn't be resolved, but they were able to negotiate for her to be transferred to a different unit, which seemed to be really helpful for her. A lot of it involved time building trust with her. She's now seeing a psychiatrist, is compliant with her medication, and is drug-free, and is trying to reunite with her family. Our next two are in an urban area in New Orleans. SB was homeless post-Katrina. This person was initially assisted with temporary assistance program and rapid rehousing funds to assist someone to get off the street as quickly as possible. She was taken from that into a PSH Section 8 program. We've been very successful within this program, working with our housing authority and the property owners in getting people accepted into the Section 8 program who might historically have been rejected because of their histories. Her disability history is that of bipolar disorder and alcohol abuse. She regularly drank until she was drunk. She was verbally combative with others and estranged from her family. She's been in housing now for 4 years and is stable. She's been sober for 3 of those 4 years. She attends her mental health appointments, and she's now taking her meds. And with the help of her staff, she's reestablishing her relationship with her children and grandchildren. And I think you'll see from these 2 cases that being sober and taking medicine is not part of the requirements for staying in housing. It all depends on how you behave. So we definitely are into harm reduction and working with people as they are, where they are. Now, Mary in New Orleans was chronically homeless when she was first introduced to the PSH program. She suffered from untreated mental illness. She was located and referred by the homeless outreach workers in New Orleans. She'd been living at the Salvation Army for 18 months, which apparently is unusual for the Salvation Army, but they had made an exception for her. She was a real engagement challenge, as are a lot of untreated mental health constituents. She avoided the PSH workers, and she avoided the homeless outreach workers, all of whom were trying to engage her. She was very distrustful. She was off her meds, having symptoms, hearing voices, fighting in the air. She thought bugs were crawling on her, and refused the medication that even the shelter was trying to give her. So after a while, she finally engaged with the PSH workers, who helped get her benefits reinstated. They got her at least into the mental health clinic, but she became so agitated during that hospitalization that she was sent to a hospital and returned to the Salvation Army upon discharge. But she did maintain contact with that PSH worker. So they found her a unit. She liked her unit. She continues the relationship with the PSH staff. She complies with mental health treatment. She pays her bills. She has been in housing for 2 months. But the whole outreach and engagement process took 4 months. So this was not an easy lady to work with and took a lot of tenacity and a lot of collaborative work on the part of the PSH staff as well as the homeless outreach workers. And finally, we have a more rural client who lived in a homeless shelter for over 4 years prior to entering PSH. Had been alcohol dependent most of her life, had a very abusive childhood, was forced to take shots of liquor at the age of 6, sexually abused by men since she was 3, lived in crack houses prior to going to the homeless shelter. At one point when she was doing drugs with friends, she was pushed over a balcony, landed on her head, and received a traumatic brain injury from that incident. However, during the 4 years she was at the shelter, she was able to stop using drugs. She did continue to drink. PSH staff helped her to find and get into an apartment, which she celebrated by getting drunk and resulted in being hospitalized. She retained her unit, however, after her discharge, and the PSH staff helped her negotiate with her landlord for her to be able to remain in spite of the commotion that she caused at the unit. She's remained housed now for 2 years. She remains both drug and alcohol free. She has started her own checking account, which she maintains by the relationships that they've established with bank employees who help her to keep it balanced. And her landlord now helps her at the beginning of each month to get groceries and make sure that her bills get paid. So I think this was a good example of our workers working with someone who not only had a tough situation but also required a lot of community resource collaboration. So those are some representative case examples, and I would like now to turn the program over to Carla.
Thank you. I'm going to go ahead and get onto my slide here. What I'll be talking to you today is about a state-funded program for our home and community-based services, and it is a rent subsidy program, and it is specifically targeting a monthly rental assistance to any eligible adult or children. If a child is in the family and receives Medicaid services, the household is also eligible for this rent subsidy. And it is only for Medicaid 1915C waiver recipients. And it is what we like to refer to as a bridge subsidy, or it's a subsidy until that tenant or that household becomes eligible for any other local, state, or federal rent subsidy. And of course, Section 8 is primarily the rent subsidy, although people certainly move into Section 202, Section 811, or some other type of rent subsidized property like a USDA 515 as well. This does assist those clients to live in the community instead of an institution. And the primary purpose of the rent subsidy program was established so that access to affordable housing was not the factor that caused you to enter an institution. The program rules are established in the Iowa Rules section, Chapter 24, and 265 is actually the section of the state rules that apply to the Iowa Finance Authority. And if you want to receive specifics about this program, about how we actually administer the program, I would encourage you to go to either the rules or our website, which I'll provide you in the end, a link to our website. And that will give you information about program rules, as well as what the applications look like, and other guidance if you wanted to implement this yourself. This program actually began in 1996. It was administered by our state's Department of Human Services, and the budget until the late 1990s was actually only $70,000 annually. And it was targeting specifically people with intellectual disability, primarily when it first started. In the late 1990s, because of efforts within our state to try and reduce the amount of individuals who were institutionalized, as well as encourage existing institutionally based service providers to deliver more home and community-based services, the budget for the rent subsidy program was increased to about $700,000. And that increase in the budget was primarily supported by the nursing home lobby because owners of nursing homes were looking at increasing the amount of assisted living and senior housing. And so they wanted to make sure that they retained access to individuals that were leaving their properties and possibly provide them services in other alternatives. However, the HCBS rent subsidy program still was a great secret. DHS did not really have the time or the energy to promote this program, and up until the early 2000s, probably only about $100,000 of that $700,000 was actually being utilized throughout the program. So in Iowa Finance, or in 2003, the Iowa Finance Authority was actually charged by then Governor Thomas Vilsack, and he's now the head of U.S. Department of Agriculture federally. He charged our agency and many other agencies to try and increase the amount of housing that was available for persons with disabilities. And as part of that effort and our statewide action plan related to that, we actually had an intern from the University of Iowa that surveyed all of our public housing authorities in Iowa and found that a person with a disability had to wait from 6 months to 2 years before a Section 8 voucher becomes available. And I would say that that issue has probably been exacerbated by reductions in the federal budget related to the Section 8 program, as well as economic problems where more people are turning to Section 8 vouchers. And so we recognized that we had a disconnect. We only had $100,000 of $700,000 that were being used in the state budget for rent subsidy, and we knew that persons with disabilities were waiting a long time for a voucher. So at that point in time, our agency, the Finance Authority, which is the state's housing agency, approached the Department of Human Services and said that we were willing to administer their home and community-based services rent subsidy program. And initially we did that at no cost to the state or to the Department of Human Services. So in June of 2004, we entered into an agreement between the two agencies, and we had internal IT staff that actually created a program so that we could automate many of the functions of administering this program. And that was a good thing because we started to serve, continually have growth in the number of people that we were serving. And then kind of in July of 2004, after we had that IT program established, we actually ran what I call a dummy month, so that the Department of Human Services paid out the rent subsidy. We entered all those folks into our system for 1 month. We compared the results, and when we worked through all of the bugs, then we transferred that program completely to the agency in August of 2004. A couple of years after the program had been transferred to us and we were doing it through an interagency agreement, the legislature actually decided to make the transition permanent and move the program and funding to the Iowa Finance Authority. The funding has remained at $700,000, and we've had to go to wait list 3 different times in the history. And when I show you the next slide, I think you'll figure out from the numbers why we've had to go to wait list. And every time we've had to go to wait list, basically we couldn't. We start the wait list when we can no longer serve all of the people that are on the program for the remaining part of the funding year. We're on a state fiscal year, and we've never quit serving anyone that has been accepted into the program. Sometimes our agency has actually picked up a few of those costs, although it hasn't been substantial to keep those folks on rent subsidy. And right now we are actually on a wait list. Over the last 3 years, because of the economic downturn, we had many people that were on one of our 1915C waivers that actually had some type of employment, usually part-time. And most of those folks have lost their jobs during this economic downturn and have not regained those jobs yet. So we had an increase in the usage of the rent subsidy program, as well as the per person amount that they received in terms of rent subsidy. So rent assistance is paid monthly via electronic funds transfer to the Medicaid waiver recipient's account or their payee. And unlike the Section 8 program that pays the landlord directly, we feel that it's important to put that money in the hands of the renters so that they have control over that rental relationship. One of the things I want to talk to you before I move on to the next slide is how we convinced the legislature and the overall government's administration to continue to fund this program at $700,000 each year. And one of the things that we do is we work with Department of Human Services to determine the average cost of institutional care versus the average cost of waiver care, and that's per client. And then we take that and times the number of unique home and community-based services rent subsidy recipients that we had during that year, and we can show the cost difference between institutional care and waiver care, and then compare that to the $700,000 that we use to fund this program. And it is significant, the savings that we show annually to the legislature by keeping people out of institutions and into the community. The current status is that we have 387 participants as of May 1st of 2012. We have more people adding than removing each month, and they usually remove because they've obtained a Section 8 voucher. So the average rent subsidy that we pay out is $161 a month. Now, I would encourage you to go out to our website and to our rules to get more information, but generally people have to become eligible for one of the 6 waivers, and they have to be responsible for paying their own rent, and they have to not be receiving any other types of rent subsidy. I'm going to go ahead and end through this, and you will have access, I'm sure, to this presentation. But for more information, you can go out to our website and go to For Renters and click on the HCBS Rent Subsidy Program. Thank you. And I'm going to be turning this back to Sabrina.
Thank you, Carla. And at this point, I'd like to offer a few recommendations for those for our participants based on what we've heard today. And really, it's important to be meeting with your state's Home and Community-Based Services lead or leads and learn about your state's HCBS programs. Learn how people are enrolled. Encourage your community to be prioritizing housing for people who are eligible for home and community-based services. learn about becoming a home and community-based service provider or collaborating with those providers in order to help them better understand the unique healthcare needs of people experiencing homelessness, and help advocate for a targeted 1959 home and community service program to sustain and grow your existing permanent supporting housing services. And we are at wrap-up. It's 2 o'clock now, but I did want to ask one question of Christine that we received before we completely wrap up. And that is Christine, can you describe how the individuals in your case example were able to access the home and community-based services program, like through enrollment? How were they able to enroll, and which of their services were supported under the home and community services program?
Yes, Sabrina. As Marty explained earlier, our system is right in the beginning stages of transferring from our disaster recovery funds to the Medicaid funding. And the plan for that is for all of our providers who are now getting paid with disaster recovery money, they are in the process of getting certified as a 1959 provider. And so in the future, what they will do is, instead of billing the state for disaster recovery money for it, they will bill the state for the Medicaid dollars for that. In terms of the enrollment for the tenants, depending on the waiver, but certainly for the I, the support teams will assist that person in applying through the state's regular process that everyone goes through in becoming part of the I recipient program. So that's one of their, that type of thing is one of the expectations of their role.
It should also be added that in the future, the staff will be qualified to bill for the I services, but before somebody comes on to I, they could be assigned to work with the person. They'll bill CDBG, and the information system capacity with the managed care company will be able to either send a bill on for a CDBG reimbursement or send a bill on for a Medicaid reimbursement. That will be handled electronically.
Great, thank you so much. And just one last thing, I wanted to direct participants to our resources. If you go to our health reform page, there's a policy brief on home and community-based services that includes a lot of the information from today's webinar. We also have some other resources for permanent supportive housing, and again, you can request technical assistance. And Julie, at this time, I'd like to hand it over to you.
Thank you for joining the Medicaid's Home and Community-Based Services Program and Orientation for Homeless Healthcare Providers webinar, produced by the National Healthcare for the Homeless Council.